Thank you for joining the City of Mason and AtriCure today as we kick off our virtual science speaker series with our topic this afternoon, clinical challenges and technical solutions for atrial fibrillation and embolic stroke. This is especially impactful that we can do this during February, Heart Health Literacy Month in the City of Mason and Heart Health Month nationally. This topic matters a lot to the economic development strategy for the City of Mason as we pursue to grow our cluster of biohealth companies specifically related to cardiac expertise here in the City of Mason. Thank you to our partners today, AtriCure, as well as the American Heart Association. We also would like to welcome our diverse audience from the members of the larger City of Mason and Greater Cincinnati community, as well as our science and technical community. I'm Michelle Blair, the Director of Economic Development for the City of Mason, and it's my pleasure today to turn it over to Dr. Lee. Dr. Randall Lee is our moderator. He is a cardiologist and electrophysiologist, a professor of medicine at the University of California, San Francisco, and also the medical director for AtriCure. Dr. Lee will be joined by a panel of experts from AtriCure as well that you see there on your screen. So welcome Chris, Sean, and Keith for participating in our discussion today. Dr. Lee, I'll turn it over to you.
Okay, thank you very much. And I'd like to share my screen so we can get started. Okay, are we set here? Yes. So first of all, thank you very much for allowing I and my colleagues to share a little bit about atrial fibrillation. And as you can tell, the name of the company, AtriCure, is based on educating and treating atrial arrhythmias. So one of the things I wanted to discuss is, why are we talking about atrial fibrillation? Atrial fibrillation is the most common arrhythmia that all of cardiologists around the world face. And as you can see in this graph, it's a huge burden in terms of the healthcare costs to the United States. And it's a disease that is continuing to grow exponentially. As you can see in this left-hand diagram here, it's presently around probably 4 million, and it's expected to double. So it's a huge economic and health consequence that we're doing. I mean, some people consider it the pandemic of cardiology. So what is atrial fibrillation? The normal conduction of the heart, we have our sinus node, which is our own natural pacemaker of the heart, and it goes very orderly from the top half to the bottom half of the heart. And as you can see in this EKG strip on the right lower hand corner, the top tracing is a very orderly, very regular rhythm. Atrial fibrillation is just a very chaotic electrical activation of the right and left atrium. As you can see, these stars is sort of depicting the disorganized electrical signal. And what that equates to on a EKG is a very fast, unorganized rhythm. Some people will describe it as palpitations. You have fatigue. Some people can't even get out of bed, so there are various extremes of the symptoms for atrial fibrillation. But one of the things, in this month of, being heart healthy, is what are some of the risk factors that are involved in atrial fibrillation? And these are some of the ones that we commonly see: hypertension, diabetes, obesity, sleep apnea, alcohol. And these are some of the things that we as individuals can take control of and try to have, watch our diet, have moderate exercise, eat healthily. If you have sleep apnea, get it treated. If you have high blood pressure, make sure it's under control. And really, this is just a slide I borrowed from one of my colleagues, which really depicts the really the epidemic of obesity. And look at the graph on the top in terms of the progression of obesity in the United States. And along with obesity comes hypertension, diabetes, sleep apnea, which all contribute to atrial fibrillation. This is just a graph showing that there's a direct correlation between atrial fibrillation and obesity. And there's been multiple studies that demonstrate if you have a little bit of weight loss, if you do moderate exercise, if you try to decrease stress, and then aggressively treat your high blood pressure, diabetes, these all will reduce atrial fibrillation. So, from a standpoint of what can we do as individuals, we can take control of our own health. However, there are times where atrial fibrillation just, overwhelms even what we do. And sort of the historical treatment for atrial fibrillation is to restore and maintain a normal rhythm and then to protect from strokes. And this really gets to the big debate of whether you should do medications or a catheter ablation procedure. And there has been recently multiple studies to suggest that catheter ablation is a more effective way of trying to maintain atrial fibrillation than medications. So I think, at this point, I'd like to invite Keith Martin to actually inform us a little bit about how we as a company help physicians like myself do ablations.
Yeah, thanks, Dr. Lee. Yeah, so we've got the privilege to work with physicians like Dr. Lee and develop tools to help him in the cath lab, and also surgeons to help treat this disease. So we really have two different types of technology. Our goal is to create these lines of scar on the heart that can help treat this arrhythmia and block the errant electrical activity that Dr. Lee was referring to. So we can do it by heating up the heart, which we use radio frequency energy, or we can do it by freezing the heart using cryothermia. So if we use RF radio frequency ablation, we've got electrodes, a catheter. In one case, we've got a catheter type product that Dr. Lee will talk a little bit more about. But we put this on the outside of the heart, and we've got electrodes on it, and we deliver current into the heart. And this current heats up the tissue, and we heat it up so that we get irreversible tissue damage, which will create a scar on the heart. And then you can create these lines of scar, as Dr. Lee is depicting here, that will help treat the disease. Cryothermia, we're looking for the same end game, where we're looking to put a line of scar on the heart. If you're using cryothermia, we get the probe down to -60, -50 degrees Celsius for a period of time, which will also create this irreversible tissue damage. And, one of the things we're very conscious of, we want to make sure that this line of scar is very precise. So we have algorithms and device modifications in place such that the scar is only going to happen within the element of the product that we have on the market. And then, getting these products to market, we have a rigorous path that we choose. So the first thing we typically do is we'll engineer and model the science behind the product. After that, we'll then prototype the device, take it into the bench, and we'll do bench and lesion testing in our bench. We then take the products into the animal, where we'll study it in the animal and also do histology to make sure that the tissue and lesion formation is exactly what we expect. Plus, we'll want to make sure that the surrounding tissues are unaffected by our ablation. And then lastly, all of our products are studied clinically in clinical trials. So we've got a robust process that takes us from kind of start to finish.
Yeah. Thank you very much, Keith. And, Keith is very modest. He and his team have created some of the tools that we're using that helps us to effectively cause or produce these lesions that make them durable, meaning that they're long lasting. And that's one of the keys about ablations, is making durable, precise lesions. So thank you, Keith. But one of the things I alluded to with atrial fibrillation is the prevention of strokes, because strokes or embolic events is one of the most severe consequences of atrial fibrillation, and it's one of the most potentially life-threatening events. And so how does this occur? One of the mechanisms for atrial fibrillation and stroke is that when the atria is beating disorganized, you have blood stagnating in the left atrial appendage. And what the left atrial appendage is just basically a little outpouching of the heart. And as the blood stagnates there, clots can form in that pouch and then go up into the brain. So it's really the irregular heartbeat, which causes stagnant blood flow, produces clots in the left atrial appendage, which then travel in the bloodstream that might go to the head. And that's called an embolic stroke. And this is just a depiction of where the left atrial appendage is. It's just a little outpouching within the left atrium, and you can see this is all the trabeculation, and that's where clots go. And what I'd like to do is invite Chris now to tell you some of the work that he's done in terms of the devices that help protect us from thrombus formation within the left atrial appendage.
Yes, thank you, Dr. Lee. That's a great overview of the appendage and what we need to do to it. And as Keith mentioned, from an ablation standpoint, AtriCure has two different technologies. When it comes to managing the left atrial appendage, we also have two different technologies. One set of technologies that we refer to as our AtriClip products, and a new technology that we have that we refer to as the Lariat technology. All of these technologies fundamentally work in a similar way in that we want to close off the appendage and not allow blood flow into and out of the appendage. And we do that by putting a device on the outside of the appendage that closes it off. The AtriClip is a spring-loaded device. The best example that I can think of to share with you would be a chip clip that you put on your potato chip bag. You put the clip in place and the potato chips stay in the bag and they stay fresh. So similarly, we have the AtriClip device that closes on the outside of the appendage. And it's that mechanical closure that excludes the appendage from the anatomy and prevents blood flow from going into and out of it. The Lariat technology is really more of a loop type technology. We encircle the outside of the appendage with a suture-like device, and we cinch that down very similar to maybe a ponytail scrunchie, where you've got a circular band that you tighten down and keep the appendage closed. The appendage management with our technologies has two important aspects. Not only does it exclude the appendage mechanically and close it down and prevent blood flow from going into and out of it, it also excludes the appendage electrically. We heard a little bit of a discussion around the electrical signals and patterns across the heart. Managing the appendage with our technologies with the Lariat and the AtriClip devices also prevents electrical activity from originating at the appendage itself. These devices stay in the body permanently, and over some period of time, the appendage basically gets resorbed into the anatomy and is no longer a factor for these diseases.
Yeah. Thank you very much, Chris. And one of the things, when we're thinking about treatment goals for atrial fibrillation, we've talked about, I as a clinician, I'm always thinking about treating the patient, their symptoms. I'm also thinking about, preventing embolic events. And really, it's more the progression of the disease, that can cause heart failure in patients. And what heart failure is an enlargement of the heart. It's a weakening of the heart. So really, these are the treatment goals. And one of the things about treating patients is that whatever we do, I as a clinician need our partners in industry. And I'd like to ask Sean Young to actually tell what AtriCure does in terms of promoting the education, not only to patients, but within our own clinical specialists and physicians.
And as Sean takes the stage, this is just a friendly reminder that it is roughly 1:20 and we will be moving into question and answer in just a few minutes. Thank you.
Thank you, Dr. Lee, for asking about this. We're very fortunate that our executive leadership team have developed 3 big pillars that we ascribe to at AtriCure. You've heard about 2 of them. We study clinical science very deeply, and then our engineering team gets to work on innovative products to be able to manage those disease processes. But as you know, when we do this, they're new, so they weren't taught to our physicians, our electrophysiologists, our surgeons, and their teams. So we have to provide that education to them and what is the latest science behind why we would develop the product to address the disease. We really have 2 pathways that we take to educate. The first one is we use peer-to-peer training. So folks like Dr. Lee will actually talk with their peers about how to address it. They'll teach in classroom settings or laboratory settings. We have a laboratory at our headquarters right there in Mason that allows us to be able to bring people into Cincinnati and be able to delve deeper into the disease states. And then we also utilize mentors and preceptors, so other electrophysiologists and surgeons to actually work in the clinical setting with the other surgeons that are learning. And this just helps them build their confidence over time so that their treatment outcomes are optimal. The other way we address this is actually through what you would refer to as our sales team. We like to call them our field team, because our field team focuses on just making sure that we're bringing the best treatment solution to each specific patient. We're not really focused that much on the products, but more the clinical outcomes. And our reps are really held to the highest clinical standard in the industry. They know the vocabulary and they understand the cardiac system at a very high level, which allows them to be able to talk with the surgeons, the electrophysiologists, and their teams on what their treatment should be.
Okay, I think it's Michelle Brittany. I think this concludes our presentation and we're open to questions.
Awesome. Well, I just want to thank you all for such an informative discussion and for your time today. For those joining us on the webinar, you can type in your questions for the panel by utilizing the Q&A function that is going to be found at the bottom of your screen. You can just type in your question and we will field those for the panel. Our first question is going to be, if I have a loved one or a family member that has just been diagnosed with AFib, what questions should we be asking to make sure that we are getting the correct treatment and the right treatment for this recent diagnosis?
Yeah, I could field that. I mean, that's a very common question when a patient will come in to my office. And I think going back to my slides, you saw, right away, it's sort of really, it's the assessment of the whole patient and what potential other diseases they may have: diabetes, hypertension, obesity, sleep apnea. So it's really, from a patient standpoint, when you're looking for someone who really understands atrial fibrillation, they should not be just focused on, oh, you have palpitations, but it really should be focused on how are you, doing in terms of all your illnesses. And then from there, I think, as Keith, Chris, Sean, and I alluded to today, it's really taking the steps down these paths of what are the options to treat your diseases.
Well, thank you for that, Dr. Lee. I really appreciate it. Another question we have submitted is, how common is AFib and how does it differ from other heart arrhythmias?
Well, the atrial fibrillation, unfortunately, is a disease of the elderly, meaning that at about the age of 50, each decade, the incidence of atrial fibrillation increases exponentially. So you could see, I think it was on the first couple slides I showed that, by the next 10 years, it's going to, double, going from about 4 billion to 8 billion, million within the, United States. So it's really, growing.
Well, thank you for that. I think at this time, there are no further questions from the participants. So I'm going to bring Michelle back in to wrap us up for today.
Well, thank you to everybody. It is certainly our sincere pleasure on behalf of the City of Mason to have each of you here. Not quite enough time to cover all the details, but as we learned from you, 2.7 million people suffer from AFib, and it is fantastic to hear that the technology being developed with the many patents and from research and development to product development, as well as training, that hopefully the AtriCure solutions become the standard of care and really help to foster that mission of eradicating this heart disease state. But in the City of Mason, we're working on literacy and certainly would like to get as many people literate around how to keep their hearts healthy. And again, it's been a very informational session. We're very pleased to have each of you here today and spending time with us. So thank you, and we look forward to hearing more about AtriCure and innovation as we move forward.
Thank you. Thanks for having us.
Michelle.
Thank you, Michelle. Thank you, everyone.
Thank you.